And with that, we will just welcome everyone to our monthly VCSQI quality meeting. Thanks all for being here today. And we have a fantastic guest lined up. Before we turn it over to Meetali, Judy, I'm just going to introduce you as our quality committee chair, and we will have a few slides to go over to kick the meeting off. So, Judy, take it away.
Okay. All right. Thank you so much. This is stuff, if you were on the call, you probably saw it. Next slide. Um, I did want to kind of plug Melinda is kind of this was normally for like it was called a new data managers meeting. Their weekly data managers meeting she's going to do for 7 weeks, but instead of just for new people, they're for everybody. I didn't join the first one, but and there's one this afternoon that's going to be 1 Eastern time, 12 if you're Central. I'm assuming that's 10 if you're Pacific. And I hope that's not feedback on me. I'm really sorry if it is. And it's definitely it's on the STS website under kind of on the sign-in page if you want to see it. But one of the things I wanted to show because it's like I've done this what 20 some years. You kind of quit looking at things, but one of the things she went over was this link under additional resources. And Curtis used to always do this list for me because when you're doing research and you're going back over the years and you're wondering what data version it is or what the thing was, what the definition was or what the feel was. Like DOAC, I think, changed over time. It was a NOAC, now it's DOAC. I just thought this was interesting, and I'm sure everybody else has looked at this and knows it's there, but I think this is really, really meaningful information, and I was glad to copy it and save it to my desktop. Next slide. This was Sweet Nancy's little slide so that it shows the data. The training sessions are going to be mostly on Tuesday. It is going to be Thursday next week, I think, and then they're the regular monthly training webinars or semi-weekly, bi-monthly. I don't even know what that's called. Semi-weekly uh, uh, STS calls also. And we've got a time before we have to, I think it's May is going to be the data submissions. Next slide. This is just going to be the topics in place because, I feel like, okay, I've harvested my data. Like I know what to do, but I feel like I always learn something. The one today is going to be that tricky proc ID chart. And if anybody has done this long enough, remember the good old days when on the website you could just go put in and answer all the questions like cabbage, yes, aortic, yes, and then it would just spit out what your procedure was going to do. And I keep begging them. I'm begging them. I'm like, listen, you qualify the vendors for this. Clearly, y'all know how to do this. Could you please just put that out there on the website? I have high hopes of Paul Meehan being able to do it. But in the meantime, we've got that tricky ID chart. I always just plug in everything to my software and see what my software gives me. But in case you're interested in it, that is a tricky thing. Case inclusion, of course, does come up a lot. I'm going to miss the first part of it, but I do think the one today will be especially interesting. Next slide. I did not know. I don't Facebook, but if you do Facebook and you're interested in having kind of a support group, kind of a bigger group, I don't know what the activity is on this. I know that the listserv does get a lot of interesting questions that I've learned a lot from just looking up the answer to the questions or seeing what other people respond to. But if you're interested in being part of this Facebook group, you can scan this QR code and I think Sherry will be sending out these slides also. Um, there's a data manager collaborative where you can have people, you can be mentored or you can get mentored and they can, just get a resource person if you're interested. And then I did put a huge plug for our regional groups last on the call last week if you were there, but it was a fun talk to give. I really enjoyed it. Next slide. AQO is going to be on October 2nd and 3rd in San Antonio. Just going to be 2 days because the Intermax and PDMax is just going to be virtual. It's going to be a live virtual, and then you can get the recordings for it, but live virtual on the 23rd. And then it's going to be congenital and thoracic on Thursday the 2nd, and then cardiac is going to be on the 3rd. It's going to be on the at the Riverwalk. I had a great time the last time in San Antonio. I went to the Alamo. I mean, which was kind of weird, like all those other tall buildings and Madame Tussauds, all this stuff around it. And then here's this, I don't know. I don't even know what it's about because I don't have a good mind for history, but it was really powerful to go. So I hope people get to go. They do not know the pricing. They are working to make it cheaper than last time. They're encouraging in-person attendance if you can, but there will be the virtual option, and obviously that'll be much cheaper because you don't have to travel and blah, blah, blah. So they'll tell us the cost as soon as they know. Next slide. This, I hate even putting this up here, but this was a March update. And in my mind, a reoperation for bleeding always said to me, you've got to go to the OR for that, or you've got to be in the ICU because we do open in the ICU, and anybody that's got the cardiac surgery unit, advanced life saving will open in the unit. But, and I'm not even sure what this means actually, but what she is saying is that if you go to interventional radiology that requires a surgical reintervention, which right there to me, I'm like, I don't know, like, how can you call it surgical if you're in the cath lab? But if you're re-explored, let's see. So this example is if you took the mitral valve, or this one was interesting. If you pop the liver while you're putting in a chest tube or something, and you go to interventional radiology to embolize the bleed, that's going to be a re-op for bleed. I know this gets really tricky. This was a little different than how I've been seeing this field, so I did want to show it. The minimally invasive mitral valve, that obviously made more sense to me because you're going to the OR, you're getting a VATS. That made more sense. So, any comments on this or any clarification for me? I would appreciate it. I think they're just trying to get all the bleeding events. I love Heather Price's idea. Can they do a new AI tool to figure out the proc ID? I don't even think it's got to be that fancy. This is clearly just yeses and nos in the data set. I mean, it would be very easy to do that proc ID, and I feel like it's something she gets a lot of questions on. Um, and in the meantime, if we go to IR to fix something in bleeding, I'll be sending an FAQ, I think. So I think that's all I have. You can go next slide. Yeah. I should have put a slide in to say thank you to all of you for joining today, and thank you especially to Meetali for teaching us.
Hi everyone. Let me share my screen and I'm going to close the video so it makes it easy. But I'll start from the same slide that I had last time. So I just will quickly go over the cardiopulmonary bypass. I'm pretty sure everyone remembers that it is just a second. I don't know why it's not letting me do something. Um, Am I still sharing? I just want to make sure.
You were Callie, but then it's just stopped.
Okay, I know. How about now?
Yes, you can see your screen.
Okay.
Cardio bypass.
Yes. So last time we went over the in-depth about cardiopulmonary bypass and all its components. I'll just quickly summarize over it that the venous cannula drains your deoxygenated blood. It takes the blood through the reservoir pump oxygenator, heater, cooler, and the oxygenated blood is returned back via the arterial cannula. And the heart is completely drained and is empty. It's relaxed by giving cardioplegia. And both of the lungs are completely deflated. So the functions of heart, which is pumping, is done by the pump, and the function of lung ventilation is done by the oxygenator and heat exchanger. So a little in-depth because it's important to understand the differences between the left heart bypass and right heart bypass. So I wanted to go a little in-depth is about the venous cannula. The venous cannula brings the blood out of the patient into the reservoir. So when it comes, especially for left heart bypass, to understand when we have to code venous cannula, and it doesn't make sense because it is on the left side of the heart. So one way to understand it, it is an outflow cannula because it is taking the blood out of the patient going to the pump. And that's why another name for venous cannula that can be thought of is an outflow cannula. And for arterial cannula, it will be the inflow cannula because it is bringing bringing back the oxygenated blood back to the patient from the pump. So it's like an inflow cannula or an arterial cannula. The other components, as I have already mentioned before, that it's the reservoir because you have to have some place where the whole blood is kind of collected because you want the heart to be empty and lungs are completely deflated. Then this is your pump, heat exchanger, oxygenator, and then there is a part of blood from the oxygenator goes to your cardioplegia system, and that is given again antegrade or retrograde. Because when we are doing a full heart bypass, we are arresting the heart also. We are completely deflating the lungs. And the total, like the whole surface area of that artificial surface for the blood that is pretty much big. Like there's a lot of tubing, lot of different machines, part of bypass machines. So it's really a big exposure of surface area. So we all know that aorta is the biggest vessel, and the diaphragm separates it between thoracic aorta and abdominal aorta. And the thoracic aorta is again ascending aorta, aortic arch with its arch vessels, and then the descending aorta. And this picture kind of gives a very good idea about how the pulmonary artery is aligned with respect to aorta. And especially when in aortic cases, the surgeons do document sometimes that the clamp is placed right above the pulmonary artery or below the pulmonary artery. And that is, in a way, helps us to sometimes figure out if the Dacron graft is being grafted mid or mid to distal part of the aorta, because sometimes the surgeons don't clearly document it. So if your surgeon is saying that he's clamping the aorta right above the pulmonary artery, it is between that mid to distal section. But if he's clamping it right below the pulmonary artery, it is just sinotubular junction to the mid ascending. Like this is just small things in anatomy that if we understand how they align to one another naturally, it makes it easy to code the sites. So now when we talk about aortic surgeries, there are 3 ways that surgeons can really fix whatever the aneurysm or dissection part is. So first is always the cardiopulmonary bypass. Like they go on cardiopulmonary bypass, and if they don't need to completely do the circulatory arrest, they can just clamp, do their repairs, and come off. Or they can just completely go in deep hypothermic circulatory arrest, do their repair, rewarm the patient, and come off bypass. So that's one way. The second way is doing the left heart bypass or partial bypass. And most of the times, the left heart bypass or partial heart bypass is done for thoracoabdominal aortic surgeries and sometimes some abdominal aortic surgeries only. And in this case, the circulatory support is only given on the left side of the circulation or the arterial side of the circulation. You don't need to arrest the heart. You don't need to, completely deflate the lungs. So that's your left heart bypass. And there's another technique which I haven't seen, but it is mentioned in the books, is clamp and sew, where they just clamp the aorta, quickly do the anastomosis, and take the clamp off. And it is most of the times mentioned more for the abdominal aortic surgeries or thoracoabdominal aortic surgeries. But then the surgeons have to be very quick, and I don't think they do it anymore. But again, there might be some place someone must be doing it. So I thought I'll mention it. So now we'll look into the differences between a full cardiopulmonary bypass and left heart bypass. I don't know how many places do left heart bypass because it's very selective to very selective sections of the aorta that they do it. In my site, we do it maybe a couple of times in a year, but sometimes a year goes by where they don't even do it. So if they don't do it, it's just for information. Don't get carried away with too much information here. So as you can see, the full cardiopulmonary bypass circuit has a lot of components, which start with the reservoir, pump, heat exchanger, oxygenator. But when it comes to left heart bypass, all you do is you drain it from one side and the pump just gives it back to the body on any other side. So in this picture, you can see it's being taken out from the left pulmonary vein, the inferior pulmonary vein. And from the pump, it is given back into the distal abdominal aorta. So as I mentioned before, like you don't take the blood from deoxygenated side. You are taking the blood that is already gone through the lungs and come back into the heart. So it's oxygenated blood. And you are not draining all of the blood. You're just taking a part of blood or a portion of blood. So it's very simple circuit, and your heart is beating and the lung is also being ventilated. So this is another example, and it's even further simplified that you're just taking the blood out from the left atrium and it is taking the blood out to the pump. So it's your outflow cannula or your venous cannula, and it is returned back, in this case, in one of the iliacs. And because it is bringing blood back into the body, it will be called your inflow cannula or your arterial cannula. The clues or the separating points are it is going to drain from the oxygenated side. The blood does not need to be oxygenated. Your heart will be beating. There won't be any documentation of any cardioplegia being given or heart being arrested. There'll be documentation that the lung is being ventilated. One of the lungs might be deflated, but most of the functions of the heart is being already, like the heart and the lungs, they will be functioning normally. So only like a portion of your whole ejection fraction is being drained with this outflow cannula. So when your heart will be beating normally, it will be ejecting and it will be perfusing your head, neck, and upper limb vessels. So you only want a part of it going down. So here you can see again, there are few more things added in the circuit, and this again depends upon surgeon preference, or sometimes if they don't have the full circuit, like the option of making selective circuits, they might end up using the full cardiopulmonary bypass circuit. But this is where it can be confusing because they might say they use the whole circuit, but in your op notes, in your perfusion record, or in your anesthesia record, you will see that the right lung is being ventilated, the heart is not arrested, and you will see that the cannulation sites are all on the arterial side of the circulation or left side of the circulation. So as you can see here, it is again drained from left atrium going through the pump, and they've added a heat exchanger, and it is being returned back into the body from the femoral artery. And here again, it's going through the left atrium. They've added a filter here, the pump, and then it is going in the thoracic abdominal aorta. So they have just clamped the descending thoracic aorta where there is aneurysm, and they'll just put the graft, and then once the graft is done, they'll take it out and come off that partial bypass. It gets confusing when they are doing abdominal part of the aorta, where they will have multiple lines where they can do selective perfusion of splenic artery or your renal artery or your mesenteric artery. And depending upon what section of the aorta they are repairing, they will be perfusing selectively those also. And this is where the left heart bypass cases get confusing, because they talk of so many things, so many lines that they are giving perfusion to the different organs. But I think if we keep it simple and understanding, like, okay, where are they draining the blood from, and where are they returning it, and what are they really trying to do? And try not to get confused with, if they talk about cooling the patient, if they say about the special renal perfusators being used to keep the kidneys perfused, or they have, nowadays they even are trying to do the vertebral arteries perfusion and all that. Basic is they have an outflow cannula that will be draining the blood, and a pump, and then inflow cannula giving back one location. So one thing that I will tell is we only need to code venous cannula and arterial cannula. And venous cannula is going to be your outflow cannula, which is from where the blood is being drained. It can be from your right atrium, as you can see, left atrium, as you can see here, or it can be aorta. Aorta can be anywhere from, most of the times they try to do it after the takeoff of subclavian. But it can be any section of the aorta. And arterial cannula or inflow cannula again can be aorta, femoral, iliac. That's the only one that you will code. We don't code all these visceral organs and renal artery perfusate or whatever extra that they mention does not need to be coded. So we only need those first outflow and second is inflow cannula. So this is what I was talking about. Like they'll have, like there's a big aneurysm, and they will go in part, and they will have these multiple perfusing lines that are going here. They have these options available to selectively perfuse vertebral artery or your renal artery or mesenteric artery. They also may talk about this renal perfusate, which is a cold renal solution of different meds, and they selectively perfuse kidneys with that to preserve it. And also there will be a lot talked about, like the clamp is placed and clamp is taken off. As they go down, first they will repair a section of it, and then they will take the clamp off, and then they'll move this clamp here, and they'll move this clamp here. So like a lot of clamp off, clamp on, will be there sometimes, depending upon the complexity of the surgery. And we don't really need to worry about all those details. Just take the total clamp time that is mentioned in the pump record, and that's all that we need to know. But the op notes can get confusing when it is done, like especially these complex aortic surgeries. Like think of, like, if you get confused, I would say just take back a step and think what is being done, and where are they taking the blood from, and where are they returning it back. So I have kind of summarized the differences between the left heart bypass and full heart bypass. Um, Again, like it is left heart bypass because you are bypassing only the left side of the circulation or arterial side of the circulation. It's also called partial heart bypass because you are just taking a portion of total ejection fraction and rest of the upper body is getting perfused by whatever is being pumped by the heart itself. So it's like just a portion of ejection fraction. That's why it's called partial heart bypass also. Um, and some tips or clues to look for when when you're reading an op note is like that differentiates a full heart bypass from a left heart bypass is first it starts with how the patient is placed on the operating table. For most of our cardiac surgeries, they are placed on their back, but when they are doing a left heart bypass, the patients are placed on the right lateral side. Um, of course, you will know what part of the aorta is being repaired. It most of the times it's either thoracoabdominal or abdominal aorta, and the incision is almost always going to be on the left thoracotomy or left thoracoabdominal, depending upon how much of the aorta is being repaired. When it comes to ventilation, left lung is sometimes it will be documented in different ways, but it is either deflated or it is mobilized or isolated, and all it means is they just uh, deflate that left lung and move it aside so that they can see the aorta, and the right lung is always going to be ventilated, and that's how it will be documented everywhere that right lung is ventilated. Then the next step is cannulation. You will see that they're not draining from the venous side of the circulation. They will be draining the blood from arterial side and returning on the arterial side. The only option that I can think they might end up doing sometimes is if they have a full circuit, they might take a portion from the venous side, but it's very rare. So that can happen. The next important thing is cardioplegia because they do not want you do not want to arrest the heart. So there will be no documentation of cardioplegia being given. The heart will be beating normally. Temperature regulation, most of the times there is no cooling or rewarming done unless it's a very long case and they want to selectively cool the visceral organs. They can do it, and then it will be documented like that. And again, like this, the most important thing is in a full cardiopulmonary bypass, your heart will not be beating and your lungs will be, both the lungs will be deflated or stop. And in partial heart bypass, your heart will be pumping, your heart will be beating normally, and the right lung will be ventilated, but the left lung will be completely collapsed. And don't get confused with multiple clamps on and off in the op note. So again, like I just made a quick reference slide where you can just figure out if it is left heart bypass or full heart bypass. So if you have any questions on this left heart bypass, we can address it now before we get into the deep hypothermic circulatory arrest.
Meetali, this is Judy. I so there's going to be some ischemic time from the clamps. In between those clamps, you're going to have some ischemic time to your intercostals or whatever, right? Unless you do that little special hookup thing, right? Like
Yes.
there's still an ischemic time. What's the advantage of doing left heart bypass?
The ischemic time is not going to be for your heart. And when we talk about ischemic time,
Well, the peripheral,
it
whatever,
will be,
body
yeah,
ischemic
yeah,
time,
yeah.
organ ischemic time.
Yes, that's what it will be. It won't be your cardiac ischemic time.
Right, right. But what's the advantage? I mean, we do this to protect your lower body and everything below, like everything in your gut. Like, why don't they do it for aortic surgeries? Like, I feel like most of our aortic surgeries are just clamp and sew.
Yes, and it all depends upon what section of aorta they are repairing. If you're just doing ascending aorta, You really don't
Well, you're
need
gonna
to have that, right? You can just clamp, arrest the heart, protect the heart, and you are already on full bypass. You are already
right,
protecting
yeah.
the visceral organs, and you are protecting the heart with your cardioplegia, and you quickly just sew and you're off bypass. So left heart bypass is most important for thoracoabdominal and abdominal surgeries. And as I mentioned, like nowadays with I have not coded a left heart bypass for almost 1.5 years now. They used to do it, then they again stopped. So that's why I said in the beginning, like if they don't do it, you don't really need to think too much about it. But there can be one surgeon who wants to do it, or there's that one case where the repair is not possible without bypassing it. And when you are bypassing only a section of descending thoracic abdomen or descending thoracic aorta or a portion of both thoracic and abdominal aorta, um, you are just isolating that section. So you like if it is just thoracic descending aorta, you're going to take from arch or left atrium the blood and you're going to perfuse it through your femoral. So that way you are supplying blood to your gut, renals,
Hmm.
and lower limb. Your heart pumping is going to take care of your upper limb and your head vessels. So the only section that will not get blood supply is probably the vertebral arteries in that section of your descending thoracic aorta. And that also they like most of the times when they do the clamping for those left heart bypass, they are very quick, um, probably 20 minutes, 25 minutes, depending upon the exposure. And that 20 minutes for vertebral artery is okay, but then they can quickly do it with, a still field and with lung being aside, they can do it. If they didn't have to, like, if they would not have the left heart bypass, then they would be completely clamping, isolating that descending thoracic aorta, and the lower body and the gut will not have any circulation. So it does help. Does it
Okay.
make sense?
Yeah. Yeah. I get it. I just guess and it's like your surgeons now doing thoracoabdominals without left heart, right? You're just clamping and sewing.
They are doing more of these TVARs.
Oh, I see. Yeah. Yeah. Okay. And then my other question is, could you go back to the proximal ascending and distal ascending, which has nothing to do with left heart bypass? But like I'll send op notes to our surgeons. They're like, well, I don't know where this ended and where this began, but if you could go over that again for me.
This
Is
part?
it's the pulmonary vein going to be the cutoff? So if it's below the pulmonary artery, sorry. If
Yeah.
it's below the pulmonary artery, it's going to be the proximal to mid ascending. And if it's
Yeah.
at, if you clamp
Because,
at it, it's going to be the mid to,
yeah. Because
okay.
and again, you can confirm this with your surgeon, but I'm like, because the anatomically, that's how it is. It's very close.
Hmm.
Like if you look at it, this is your sinotubular junction, and
Sure.
here is where your distal ascending ends.
Hmm.
So this is not really that big of a portion, but this is kind of its mid. And when they say sometimes even for distal, they clamp right here, like they go
Hmm.
sideways. And most of the times in that scenario, I have seen my surgeons saying that they put a clamp above the pulmonary artery.
Hmm. Yeah, I see it sometimes. Okay.
So it's again like small things, which you can always
That was
like
very helpful.
if you confirm with your surgeon that okay, is that what it means once, then you have that, you don't have to ask him all the time.
Hmm.
So every
Totally
surgeon
got it.
is kind of a little different, but
Yeah, that's,
yeah. So the way we try to do it is like when we see something in our surgeon's op note, we do talk with them, we do confirm it with them, and then we know that whenever he mentions it like this is what it means.
hmm. Sure. Thank you.
Mm. Okay, so should I start the deep hypothermic circulatory arrest? Or anyone has any question on left heart bypass?
Does anybody else have any questions?
Because I can't see the comments, so I have no idea. Okay, I'm
I'm
going
looking
to,
at the chat. I don't see anything.
yeah.
I think you're ready to go.
Okay. So now the deep hypothermic circulatory arrest, and this is what it will look on your screens because there'll be no blood flowing through the patient because the pump is stopped. The monitor will show complete asystole. The EEG would be silent. There'll be no pulsatile waveform. All the numbers or values of systolic and diastolic pressure or your CVP, PA pressures, everything would be like uh, all over the place. So in certain cases, it is impossible to really operate, even if we have a bloodless field like we normally have on bypass. And some of those cases are pulmonary embolectomies and especially the dissections that go into your arch vessels and descending aorta that start at the root, and some aneurysms that are going beyond arch vessels. So we might think like, why can't they just stop the circulation and quickly do the anastomosis and come and do it? But if they don't do a hypothermic circulatory arrest, your brain can only survive for 3 to 4 minutes without oxygen and without any supply. And this is where deep hypothermic circulatory arrest comes into picture, because once you arrest the heart in hypothermia, you are reducing the metabolic demands, you're protecting the organs, and then it's safer to do it. So deep hypothermic circulatory arrest is like surgically induced hypothermia. And as I mentioned before, it is done for aortic surgeries and also pulmonary thromboembolectomies. It provides a bloodless field with a better visual scenario for surgeons. And because there is no blood flowing through the vessels, the surgeons can open the aorta or pulmonary vein in case of pulmonary thromboembolectomies. It is always going to be a very well-planned procedure before even, starting it. So everything is planned, from how to pull the patient, the meds that are required, how are they going to protect the organs, and how long it will be. It's all well planned before even it starts, because you want to make sure that all the organs are well protected, especially the brain, because you want to make sure that there's no free radical accumulation, there's no swelling of the brain that happens, there should be no damage to the brain vessels, and the intracranial pressure should stay normal. So as the name says, it's hypothermia, which means you cool the patient. And when I say cool the patient, you want to cool the patient to the core, like not only externally, but it has to be the internal core of the patient to be cooled. And how much the patient is cooled, or to what temperature the patient is cooled, decides how long you can do the circulatory arrest. So these are the terms nowadays that are being mentioned a lot in the op notes, like mild hypothermic arrest or moderate hypothermic arrest or deep. And all it means is how much the patient is cool, like, to what temperature. And again, as I said, it's a planned procedure. So depending upon how long they are expecting that the repair will take, they will choose if they want to do mild or moderate or deep. But for STS purposes, whether it is mild, whether it is moderate or deep, everything goes in as a deep hypothermic circulatory arrest. And in all this, temperature monitoring is very crucial, is critical, because you want to make sure that the patient really is cooled well. And secondly is your brain protection. So how is it done? So you want to cool the patient externally also and internally from the core. So externally, it starts with dropping the temperature in the OR, packing the head with ice, having cooling blanket under the patient. And as I mentioned, there'll be like monitoring being done. And once you go on pump, you drop the temperature of the pump, and the cold blood is flowing through the patient. So you are cooling the patient internally also. And a lot of places probably don't even see the perfusion records, but perfusion machine also has its own temperature probes for the venous blood and arterial blood. And when it comes to circulatory arrest, if the surgeon decides what the temperature he wants to cool at, they want to see the venous return temperature, blood temperature, to be at that number before they even go on circ arrest. So once that temperature is achieved, they give the meds for protecting the brain and to reduce the, to control the pH and everything. And once the cerebral activity completely ceases, they stop the pump. Once the pump is stopped, you're not giving any blood back into the patient. All of the blood is being drained on the venous side of the reservoir. So reservoir holds that blood. And once the patient is completely empty, the surgeon opens the aorta or opens the pulmonary veins to do the thromboembolectomies. And once that repair is done, the recirculation is started. The full bypass is again reestablished, and slowly the patient is rewarmed. Cooling can be done very quickly. It really is quick. But when you start rewarming, you really want to go very slow, because if you rewarm very quickly, chances of organ injury at the cellular level is very high, because it can cause activation of a lot of different pathways and can create inflammation and cell injury. And also it has increased chances of gaseous embolization. So rewarming takes longer than cooling. So this is what is done in deep hypothermic circulatory arrest. Now, with respect to monitoring is a very crucial part of any surgery for that matter. But when it comes to deep hypothermic circulatory arrest, it becomes even more multifaceted, or it has so many things that you really need to look at, apart from just the routinely looked things like about the anesthesia, depth and oxygenation and ventilation, use and circulation. And you also need to monitor temperature, you need to look at the brain activity, you want to look at the cerebral oximetry and all those MEPs and SEPs and all that we see in the aortic section, because you want to preserve and conserve all the activities, and you want to make sure that they are fine. So again, what is monitored, what is not monitored, it varies based upon all the different centers. But like whatever I have mentioned are most of the basic things that I believe most places do monitor. So as I said, like it's temperature monitoring, it's the EEG, and like all this information is important to decide how long they can stay, or how quickly they have to finish, or how quickly they can come off. Even after they come off, how they are rewarming, how the brain is responding, and all those things. This is just a quick reference for how many different temperature sources can be used. I don't plan to go in depth on this, but as you can see there, like I have mentioned, like what is there and what it measures, and what are the advantages and disadvantages of all these different temperature sources. With respect to cardiac surgery, the reliable sources are esophageal, nasopharyngeal for our routine CABG cases. For aortic cases with circulatory arrest, bladder is a better choice, because it gives you a good idea of your core temperature. And once you cool the patient, the urine production drops. But then once you start rewarming gradually, your urine production starts, and that gives a better idea of how the visceral organs are also getting rewarmed. Um, and of course, you have the pump temperatures. Again, you will look at the venous temperature also. And peripheral sources are not so good and reliable, because when you cannot be sure how much peripheral your patient is lying open in the OR, his limbs peripherally are exposed. Same as with PA temperature, because the probe is sitting in your pulmonary artery, right? Chest is open. So those are not reliable sources. The next thing is like protecting brain. And the whole process of the cerebral protection is very complex. As I already mentioned, it depends upon how much you're cooling, how long you're planning to stay on circulatory arrest. You have to plan and give the proper medications to protect the brain. And then the next thing is like, do you want to perfuse the brain selectively to protect it from damage? And you can think of it similar to our cardioplegia. So we already arrest the heart, but we still give cardioplegia because you want to protect it further. Like you go an extra step to protect your heart. So cerebral perfusion is also similar to that, in a way that you have already cooled the brain, you're already giving the meds, but you want to take an extra step to protect it further, because just to make sure that no part of your brain is damaged. And that can be achieved either by antegrade cerebral perfusion or retrograde cerebral perfusion. They are very complicated, and again, as much as they are beneficial, but they also have their own disadvantages, because you have to make sure that you do not injure your vessels, brain vessels, and at the same, so it's important that you monitor the flow and pressure and make sure that it's going the right way that you want it to go. So here you can see the antegrade cerebral perfusion. Antegrade cerebral perfusion can be done through your axillary artery or through your left or right common carotid. And you can either do it by cannulating the arteries, like the arch vessels, selectively, or through your axillary artery graft that you are using for going on pump, or something like this also, like you just put individually cannulate those arch vessels and then you flow through that. So as I mentioned, like this is very sensitive. These are all sensitive vessels, because the chances of causing a tear or chances of injuring the arch vessel, if your pressure is too high, you can even damage the brain cells. But this is your natural flow. This is your forward flow, or this is your antegrade flow. So this is how naturally your brain gets perfused. So it is a better approach, better way of flowing it. It is believed that it flushes the toxins better. It controls the temperature of the brain better. But the biggest disadvantage with the antegrade is possible injury to your arch vessels, your brain, and also the spinal cord injuries. And the next is retrograde cerebral perfusion, which, as the name says, it's retrograde. It's the backward flow. So it's against your normal flow. So what it is done is it's always done through your SVC cannula, the superior vena cava, and it goes backwards or opposite the natural flow. And the surgeons can see that it is being returned from, like, the deoxygenated or the dark blood is seen coming out of the arch vessels. And this will be again documented in your op note very clearly. So the disadvantage of retrograde cerebral perfusion is, like, because you're going the opposite way, there's no unless the whole circulation is really open and straightforward, you cannot be sure that you're perfusing the whole brain. And the internal jugular vein or some veins do have valves. So that's again is questionable. But surgeons do see good results, and there's some surgeons who believe retrograde is better than antegrade, and the surgeons use it based upon what they are comfortable with. So in this, I just will walk you through how the retrograde is done. If it gets confusing, that's fine. Nobody, you don't need to know it. Um, the only thing you need to know is retrograde is almost always given through superior vena cava cannulation. So as you can see, this is a bicaval cannulation. They go on pump with bicaval cannulation, and the blood is returned back into the aorta. But as you can see, there is this connecting bridge, and this is clamped when you are being on cardiopulmonary bypass. So once they go on circulatory arrest, because they want to give the oxygenated blood through the SVC cannula to the brain, this arterial side, this one that is going to your aorta, is clamped, and the clamps here on the bridge are opened. This drainage is going to continue because you still want, if you're giving back patient some blood, something might come back, so you want it to be open to drain. And you have a clamp here, so when you're flowing back, you are perfusing the brain from this SVC cannula. So as I said, the pump has a lot of tubings and a lot of clamps here and there, but I feel like this explains it very easily how it is achieved. But again, I'll say you don't need to know this. It's just, I thought it's cool. Another thing that I read in few articles that is being used out there in certain centers is some newer techniques to protect brain and spinal cord. Further is cooling, like using special cooling catheters that are placed intraventricular in the brain. So they're called like intraventricular brain cooling catheters. And the other thing is spinal cooling catheters. We don't use it. We don't need to worry about it in STS because we don't code it there. But this is something that is coming, and who knows, it might be added down the lane. So again, some of the terms that you will see in deep hypothermic circulatory arrest in your op notes is, they might say it's temporary hypothermic extracorporeal circulation, or moderate hypothermic arrest, or hypothermic circulatory arrest, or mild circulatory arrest. So the key is circulatory arrest. Mild, moderate, deep are all referring to the temperature, and it doesn't matter. We need to code it as circulatory arrest only. And the last thing is, I kind of summarized, what are the questions and what you should look for. I just want to tell you, like, there's a group of friends and we started learning crochet, and my daughter is teaching us, and we all knew simple chain stitch, and then she was talking about all these different stitches and how it looks, and we were like, we want to do something like this, but we don't think we can even understand it. But then what she said is like, you have to just take a step back and learn the basic concept of what it is. And once you understand basic, like if you do it this way, this is what's going to happen, you will understand what is being done and how you need to do it. And I feel like with cardiopulmonary bypass or any surgery that we code, that's what we should, think about it. Okay, what needs to be done? How is it done? And if sometimes as data managers, we read too much, we get too much in depth of it, and we really don't need that information. So when that happens, just take a step back, think what is being done, how it can be done, and I'm pretty sure you'll figure out what it is. And that's it. Oh, well, what happened? Okay, thank you.
Um, but Holly, that was fantastic. We have a lot of people asking for the recordings and your slides. And Sherry, can you speak to that? I think that if you're not part of VCSQI and we don't have your email address unless you RSVP'd, is that true, Sherry?
That is correct. So I will find the posting from the last session and post it in the chat and send it to everyone as well. But if you RSVP for this event or are a member of the quality committee, I will send you the link up to the recording so you can access it at a later time.
Thank you so much, Sherry. Would you mind when you send that to send part one also?
Absolutely.
That would be great. And then, Meetali, I had a question. We only have like 3 minutes left, but it seems like they put in some. So, say you're going to do all your head vessels, or say you're going to do they're going to, like, I'm going to do this right. They're going to do a graph to the carotid and the innominate. Okay. So, they
Mhm.
have, they go to the store and they buy this little special graph that's got all those little tubes sticking up out of it. And then there seems to be like an extra one that after circa rest, they cannulate. They'll go ahead and put the pump back to
Yeah.
that little extra hose that's sticking out. Does
Yeah.
that get coded? I have been coding that as other,
Yes.
like when it
That
looks at
you're
your
right.
other at your cannulation. I forget what it's called, but it's called aortic cannulation. I've been coding that as other, but I'm not sure I'm supposed to.
Yes, you are supposed to.
Okay, all right, good.
So
I don't
that
feel like I
does
just
get
read
coded
something
as.
that was crazy.
Yeah, no,
All right.
that's correct. You do code it as other, because that's not your native aorta, or that's not even the graft that is acting as your aortic graft, aorta. It is an extension, so that does get coded as other.
And the other thing is people are trying to help me out with this bleeding issue. And whether it does include the abdominal cavity. One of the things I learned last week is a definition can never change. So once they say bleeding in the mediastinum, a definition can never change, but they can change, the FAQs and everything else, like they can update. So it is abdominal cavity. We're having a question now of whether it's index procedure only. I would say if you've got bleeding going back to IR and you've got questions, we're going to have to send FAQs at this point, unless Callie or Heather would like to speak to this issue in the 1 minute we have left. It's probably a little more complicated than we could get into, but
I think it's
Melinda's
very
your
case
friend.
selective. I think, as you said, it's very case
Yeah,
selective, and I think if
yeah,
you come across, it's always good to ask Melinda. Um,
yeah.
the way I interpret it is like any bleeding anywhere, if it is happening because of the surgery that is being performed, I think it needs to be coded as reop for bleed. That's how I am interpreting it.
Okay. All righty. The IR was a new one for me though, Meetali.
Yeah.
We are at time. Meetali, this was fantastic. You need to take this show on the road. You're amazing. We really appreciate your
You.
time. I appreciate all of our visitors today. I'm so happy to see all these names in chat and up on the participant board. We really appreciate you and thank you for taking the time to attend today. And Meetali, we can't thank you enough.
Thank you.
And
Have a
you
good
go look at
one.
the chat. Go look at the chat real quick before you hang up so you can see it. So we really appreciate
Thank
it.
you. Thank you.
Thank you.
I'm
All right.
glad I could
Bye-bye.
be of help. Bye.
I am glad too. So thank you all. Bye
Yeah.
bye.
Bye. Talk to you later.
Thank you, Meetali. Thank you, everyone.
Thank you, Eddie. Thanks, Sherry.
No problem.
All right.